on polyvagal theory. Okay, we're being recorded. I can see that. Okay. By Deb Dana. Clients with trauma histories often experience more intense, extreme, autonomic responses, which affects their ability to regulate and feel safe in relationships. I chose this quote because it highlights several key aspects of what we're going to talk about here today. First, trauma. Sibi is going to explain a little bit more how perinatal, and first define perinatal, and how perinatal experiences can be traumatic. And then I'm going to connect this with the response of the autonomic nervous system, which is only one part of our nervous system, and its role in helping us regulate our emotions and detecting cues of safety or danger in our environment. And what does that mean for counseling? So I think this quote captures a lot of what we're going to talk about here today. And I keep playing with everyone's image here, and it's always in the way. Okay, I think we'll leave it there. I don't know if you all can see exactly what I can see, but I hope it's out of the way.
What I see is okay.
Okay, good.
Okay, so we start with the definition of perinatal. I found several definitions of this term in the literature, but for our presentation, we use the last term that is includes the wider period. So this includes the period starts from 1 year before birth of a child, or when people decide to start to trying to conceive, and the period can end about 18 to 24 months after the birth of the child. So the reason that we take this long period of time is because even when the child is not yet conceived, it's in some ways usually exists in the mind of the parents. Doesn't matter if it is planned or not. Like usually everybody has some idea about what they want their offspring to be, and there is a certain type of attachment long after the child is born. So that's why we use this term that is long. Now, as this is a long period, of course, there are many events that can happen in this period. And here we include infertility, early pregnancy loss, which includes ectopic pregnancy, miscarriage, termination of pregnancy by choice, or termination of pregnancy for medical reasons. There is also stillbirth, preterm birth. There is illness of infants and stay in the neonatal intensive care unit. Also different types of traumatic birth experiences and events that can happen in the hospital. And at the end, it is sudden infant death syndrome. Okay, as I said, the research of perinatal trauma is very limited. A lot of it is focused on depression and anxiety, not so much on the trauma. However, I was able to find some studies that reveal that these events during the perinatal period can lead to symptoms of PTSD. And it's important here to remember that the trauma, the perinatal trauma is related to both physical and physiological and psychological trauma. And as you see, like many women show PTSD symptoms long after pregnancy loss. Also, many parents of babies who have been hospitalized in the neonatal intensive care unit show symptoms of PTSD. That's what I could find in the academic data.
Thank you, Sibila. I just wanted to, again, connect polyvagal theory here real quick. Pregnancy loss inflicts both physical and psychological trauma, and this is why we need a theory, a model that addresses both. And polyvagal theory does that. It tells us what happens in the nervous system and what we can see on the outside in terms of behavior, emotional expression, facial expression, nonverbal, verbal communication as a result of that. So here's a little bit of an introduction. Dr. Stephen Porges was interested in the role of the vagus nerve and its relation actually to some cardiac events and the role of and its connection to the tone of the heart in the 70s of the last century. So research has been emerging since then. And nowadays we have a really more complex and very well developed model of how to use this knowledge of the vagus nerve. Where is it? What does it do? And how does it react to trauma? How can we engage it to heal trauma? I am going to show you a few different ways to use it, but just let me define briefly the role of the vagus nerve. So the autonomic nervous system is the part of our nervous system that we're not aware of. It regulates all of these vital functions of the body all the time, keeping us alive, monitoring our environment for safety or danger cues, but we're not aware of it most of the time. It goes unnoticed. Now that now we know much more about what it does. We can actually engage it and take control of it. The vagus nerve begins at the sort of at the bottom of the skull, goes down through our body. It has connections to the heart and the gut, and with multiple other smaller nerves, and it really helps us regulate our emotions and our sense of equilibrium. So I'm going to say a little bit more about that in the subsequent slides. And for those of you who are interested, I have shared just the covers of the two really, really good sources of where you could learn more about the model and the theory. The one on the right is written by Stephen Porges and Deb Dana. And I think it's a little bit harder to read. I prefer the Polyvagal Theory and Therapy by Deb Dana. It includes actually worksheets that you can use or you can recreate to use with your clients, and it's just much easier to comprehend. So here I will touch on a little bit on 4 main concepts with this theory. First, neuroception. To really simplify it, neuroception is our ability to focus on what happens inside our body, what we sense in terms of emotional states or just sensations within our body, any cues that our body is giving us as to that may impact our emotions. Neuroception. Co-regulation. So our autonomic nervous system is active all the time. Again, outside of our awareness a lot of the times. And it's scanning the environment and even trying to predict whether we're going to be safe in the near future, whether we're safe now. So it's scanning our environment for, if you have a boss who is angry with you, that may be a cue of danger. If you see a lot of traffic in front of you while you're commuting, that may be a cue of danger. That may send your nervous system into a fight or flight mode. So it could be various things out of your environment, and the opposite. If you are perceiving around you cues of safety, then you are going to go into a state of contentment and calm, and maybe even happy or blissful. So what we, in the language of polyvagal theory, say that counseling does is co-regulation. When you look at your therapist or counselor and they have a calm facial expression, a soft tone of voice, empathy expressed in their body, in their eyes, in their reflections. This is a cue of safety. They're co-regulating with you. Their autonomic nervous system is telling your autonomic nervous system that you are safe. And even Carl Rogers knew this years ago and said that we should create a sense of safety in our offices, but now we know in a deeper way how this works. So the vagus nerve, the theory is called polyvagal because the vagus nerve has two parts. One of the pathways really is responsible for bringing us to sense of, like I mentioned, calm, contentment, maybe even bliss, happiness, feeling connected, feeling like being around others. This is the ventral vagal pathway. The other one, however, can really immobilize us in a case of severe danger or trauma. The dorsal vagal pathway. This is when you may see someone in a state of shock or not even able to speak, or they may describe their experience as feeling numb or frozen. And I will tell you a little bit more about the autonomic states. There are, we could say that there are roughly 3 of them, and I will show you a little bit more in a little bit. Okay, so here's in a little bit more detail. The vagal system is part of the parasympathetic nervous system. The dorsal vagus, like I mentioned, can immobilize you. The ventral vagus at the bottom here is active when you're with people you trust, when you feel safe. And the sympathetic nervous system, this is the outer branch of the autonomic nervous system, really gets you mobilized. Anywhere from just being ready, maybe just right after you had your coffee in the morning and you're ready for your day, to maybe even in a fight or flight, ready to overcome a big challenge. This is your sympathetic nervous system.
Now, the first traumatic event that we'll introduce is infertility. Infertility is a medical condition of the reproductive system, and usually it is diagnosed after 1 year of not achieving a successful pregnancy. Here there is a common misconception that infertility is a women's condition, but the reality is that it happens equally for men and women, and actually about 20% of infertility cases are for unknown reasons. So you can see next slide and the next one. How can infertility be traumatic? So usually when we think about trauma, we think about experience that is life-threatening, and also this is a part of the definition in the DSM. So how can infertility be traumatic? The question is here, is it a life-threatening? Even though it is not directly life-threatening, actually for somebody who struggles with infertility, the inability to create a life is perceived as equally traumatic. And there is a research that shows that stress experienced from infertility can be compared with stress that people experience when they have cancer or other terminal illnesses. So infertility is related with a strong feeling of shock, helplessness, shame. There's a lot of self-blame. It is a reproductive loss and is perceived by parents as a loss of entire life stage. It is important to know that parenting is a normative event. So when it doesn't happen, it can be a big loss. Also, the treatment of infertility is related to like very invasive medical treatments. They require strong physical, emotional, and financial commitment. Then they can be very painful, humiliating, and intrusive. Also, they are very expensive. So one single in vitro fertilization cycle can cost between $12,000 and $28,000, and usually one cycle is not enough. So it's many times it is not successful. Also, it is a taboo topic, so people don't often talk about this openly, which limits their ability to receive support. People who struggle with infertility may get overly involved with their treatments, and they can start trying different diets, supplements, herbs. Oftentimes they are not approved and they are not tested, but that's the only way for people that can feel some sense of control and to overcome this feeling of being inadequate. So the effect from infertility is social isolation and withdrawal. There is a struggle of the sense of self because of the shame. It can lead to marital and sexual problems because now sex is no longer for pleasure. It has a purpose. It has to be scheduled. It may be like monitored by medical professionals, so it can cause these marital and sexual problems. Also, it leads to increased risk to develop PTSD. When a pregnancy is achieved, it can be very stressful because in the medical field it is considered to be high risk. And also there may be flashbacks and intrusive thoughts. For example, I talked to one woman who shared that even though she had a successful fertility treatment, she was already pregnant, but she was sometimes waking up in the middle of the night, like feeling afraid that, oh, I'm sorry, I don't see the screen now.
I'm so sorry.
No, it's okay.
That was me. Here we are.
So this woman shared that even though she was already pregnant, she would wake up in the middle of the night being stressed that she missed an injection or she didn't do something right from her treatment. And also in a pregnancy, there may be a failure to bond with the newborn, or the bonding to happen a little later in an attempt for women to protect herself.
Thank you, Sibila. If I may add something here real quick, is that when a woman has experienced infertility, then in terms of the polyvagal language, a woman can experience both her sympathetic sympathetic pathways of the nervous system can be activated a lot, being engaged a lot in the process, in going to medical appointments, and just being very active and tense and experiencing a good amount of stress. But also a woman could go into the level of immobilization at times, feeling numb or paralyzed in a sense when the dorsal-vagal pathway is activated. And if you also remember, only one of the vagus pathways actually promotes our desire to connect with others. So that leads to the risk of infertility, experiences of infertility being misdiagnosed as depression because our ability and desire to engage with others is impacted.
Thank you.
Trying to switch to the next slide, and here we go.
Thank you. So early pregnancy loss is a loss of a pregnancy before 20 completed weeks of gestation, and there are several types. Ectopic pregnancy is when the embryo implants outside of the uterus. This is really a life-threatening event because the embryo cannot develop, and it can cause a rupture of tubes. So it is a medical emergency and requires the pregnancy to be terminated. Then miscarriage, which can happen naturally, or with a medical procedure. Sometimes there is termination of pregnancy for medical reasons. If there are fetal abnormalities and the embryo is considered incompatible with life, sometimes it's like parents are given choice to terminate the pregnancy because it will not, like the baby will not survive. And there is also termination of pregnancy by choice, which is like even though it is considered to be voluntary, still it may cause some problems long after the event. So how can early pregnancy loss be traumatic? As I said, it can be life-threatening, especially when we are talking about ectopic pregnancy. There are emergency surgery procedures. There is sight of blood. Sometimes women can see a fully formed fetus. Sometimes the loss of the pregnancy can happen in just outside, in the metro, at workplace. So there are also difficult ethical decision involved when there are medical reasons to terminate the pregnancy. And of course, it's also causing isolation, lack of understanding from society, and there is a lack of grieving rituals.
And I realized that I should have mentioned something else when I spoke a minute ago. I said a woman, but we have been talking with Sibila to be aware that not only women are impacted by all of these experiences, not only the mother, but their partners, and sometimes even, other members of the family.
Yes, thank you. So the psychological impact of early pregnancy loss, again, as I said, the data is limited, and it depends when it was collected, the type of the loss, and the research design. But overall, there are findings that it leads to depression, anxiety, PTSD, and some attachment issues in the next pregnancies, and difficulties. And generally women report more traumatic symptoms than men, but men also can experience that.
One more thought here I wanted to add is, if you notice, it's almost equally distributed, the percentages of depression, anxiety, and PTSD diagnosed. Polyvagal theory is bringing some interesting new perspective to even our ability to diagnose. It is a whole new language, and through the perspective of activation of the 3 different branches of the autonomic nervous system, we're not even thinking about anxiety, depression, or PTSD. It's just nuances of similar level of activation. We could say that depression and anxiety are 2 sides of the same coin. I don't know how many of you would agree, especially if you've already worked with people in the mental health field, but how often is it that depression and anxiety come along together? But here, instead of the DSM symptoms, through the language of polyvagal theory, we think of, was the dorsal nerve activated, was the sympathetic nervous branch activated, or the ventral? Ventral is when the ventral is when we feel well and okay and safe.
Now, perinatal death, this is depending on the stage that the loss happens. Perinatal death is a loss of a baby after 20 weeks gestation, and here it is important to distinguish stillbirth, which is when the baby dies before being born, and then if the baby dies soon after birth, it is considered perinatal or neonatal death. And then we have a little bit of statistics. It is important to mention that almost every day, not every day in the United States, almost 100 babies are stillborn. And in 2017, there were 4 to 8 perinatal deaths per 1,000 births. So it is a huge problem, and we need to address that. Now, how can a perinatal death be traumatic? Of course, the more we move ahead of the stage of the pregnancy, we see that it's more evident how it can be traumatic. However, there are many things that people who have not experienced, they don't know. So, of course, there is, with perinatal death, there is sense of shock and emergency. There is also something that we don't think about, is that it's a real birthing process, but with none of the expected surrounding rituals. For example, the stillbirth can happen in a room that is dark, the light may be dimmed, there may be not too many medical health professionals like in the regular birth, but maybe just one. Like, baby is born, but he's not crying. So this is like, there is no rush for some medical procedure to be done right away. So it is a way that it is different from the expectations that parents had. Also, the image of the baby can be disturbing. Depends how long it has been before the birth. There may be change of the skin. There may be some malformation, which can be disturbing. Also, there is very often there is a lack of appropriate support from the medical staff. Again, it is a traumatic bereavement, but there is lack of acknowledgement and rituals when the baby is born dead. Then suddenly people have to plan a funeral, even though until yesterday they were buying maybe a crib, they were planning a baby shower. They have to face a lot of social misconception. Like, people may say, like, why are you so sad? Like, you didn't know the baby. It's important to know that there is also physical impact on the mother, because it was a real birthing process. So she still has to recover. Maybe she had a C-section. The birth experience maybe was difficult. Like, something that happens for mothers is that their milk will come after the birth, but then they have no baby to feed with this milk. So this is something that can be experienced as a very traumatic. It is experienced also as a loss of part of yourself, loss of identity, because people are wondering, okay, now we gave birth to this child, but are we parents or are we not parents? Who we are exactly? Of course, loss of part of your future, because everything that was planned is not going to happen now. And loss of purpose in life. The next slide talks about preterm birth. Here there are also some misconceptions, because society usually thinks, okay, the baby was born, he will be okay, he will survive. So they don't know why parents are so distressed. But actually, it is very distressing, because babies who are born early, they have a lot of problems, like with breathing, with feeding, and they're still at risk of death. In the next slide, I also discuss a little bit how it can be traumatic. Here we have to mention that mother and baby are very vulnerable. Appearance and the behavior of a baby can be distressing, because their skin may be different. Again, they may have some malformation. There is a lot of medical language, a lot of technology involved. Parents are very vulnerable in front of the medical authority, and it is difficult for parents to leave the hospital and leave the baby there in the NICU. And also there are some reaction of the body, like I have heard women sharing that when they went home and their baby was still in the hospital, they would wake up in the middle of the night looking for their baby. And so they are in a high distress, but again they lack understanding and support. And so yeah.
Sibi, and correct me if I'm wrong, but what I have learned is that immediately after perhaps leaving the hospital, and if there's a funeral, these are the times when especially the mother is likely to be on high adrenaline. So this is when the sympathetic nervous system is really on. And of course,
Yeah.
we cannot sustain that. So a few days or maybe a week or two, I'm sure it varies, then this is when we may go into more of a state of where our dorsal vagus is active, and we may appear to have depression, but of course this is often misdiagnosed because this is just the effects of the trauma.
Yes. Now, sudden infant death syndrome is another traumatic experience. It happens when a child dies before 1 year of age. It can happen for various reasons, and it is obviously a traumatic event when you lose a child. But here, what is specific and that I would like to mention is that sometimes when an infant dies, parents can actually be arrested and interrogated for possibility of abuse and neglect. So you can imagine they have just experienced the death of their child, they are still in shock, and now they are also in this situation to be like maybe blamed for what happened. So it is on top of their self-blame and guilt that they experience. And of course, it is causing severe grief reaction. Um, so these are traumatic triggers. These are events that can trigger the traumatic reaction of the people. And as you can see, these are events that are all around us. So they can happen anytime and every day. Like every time people see babies, hear babies cries, they see ultrasound pictures, a birth announcement, other pregnant women, baby showers, when there are holidays, when they have to visit doctor's office again. All these are like when they are asked, do you have children or how many children you have? These are events that we usually don't pay attention. They are all around us. But for people who have experienced these events, it's very distressing and it sends them right into this traumatic experience.
And again, to put immediately our counselors' hats on, just how empowering and normalizing and validating can it be if you as a counselor working with a person or a couple who has experienced perinatal trauma, for you to talk about these and to acknowledge that you understand that these are triggering events, and eventually to prepare your clients to face them with a little bit more inner strength, even though you recognize that they might be traumatic. They may elicit immobilization, shutting down, a lot of suffering, of course, flashbacks, nightmares, all of the symptoms of PTSD as well. So again, let's talk a little bit more. Let's connect this to the polyvagal language. Again, we have 3 autonomic states, and each one of them is a result of the activation of one of the branches of the autonomic nervous system. So the first one, where I have a picture of 2 parents holding and smiling, holding a baby and smiling, I use this to illustrate when your ventral vagus nervous is active. But even just no matter what your experiences have been so far, just if you remember a recent moment when you felt happy and content and safe, maybe it was while you were sipping your morning coffee, gazing out the window, For me, I can remember vividly one of the times I was reading my book by the Potomac River in the park last summer. This is when you have serotonin and dopamine and even oxytocin maybe secreting in your nervous system, and this is when your ventral vagus nervus is active. And this is when you are likely to feel connected to others. Sympathetic, when your sympathetic branch is active, again, on a continuum between feeling ready, alert, to feeling very stressed, very tense, very on, fight or flight. This is where I have an image of an infant in the NICU unit. I would imagine that in many cases, having for the parents, their sympathetic branch is active in those cases. The dorsal vagal. This is the hardest. This is when our clients may not even be responsive to us if they're having a flashback or if they're shutting down, if you can hardly hear their voice, if they're hardly moving their body. This is when the dorsal vagus nervus is active, when they're reliving a traumatic event. And really how delicate it is to work with people who have experienced perinatal trauma. Countertransference is such a high risk if you don't understand the previous list of the triggers, and you fail to prepare your client for one of those or to explore to support them through one of those. This is another way to illustrate the 3 levels of activation, but they're broken up here to 6 levels. And I actually, let's see, if I stop sharing for a second, I have this handout and where we can see it better, but we can actually see it pretty well. Can we, Sibi, do you think we can see it well? Let me try to bring up the other one. Okay, I think this is a little better. So I just love this resource. You can see at the bottom, I forgot to remove the note, do not remove, because someone stole my first handout from the office. So I had to buy another one and make a note that nobody steals it. I love this. I use it with couples, families, and even children to teach them, especially the colors help, teach them that our nervous system goes through different states of activation. Sometimes you may feel red, orange, or even yellow. So in this case, you can see at the top that the, let's see, the blue, orange, and red are blue, orange, yes, and red. These are the states of activation that are a result of the sympathetic branch of the nervous system, whether you feel just kind of alert, ready to act, react to danger, or whether you're actually afraid for your life and you're just sort of freezing, trying to figure out how you can escape. The green illustrates, and you can see all actually the different physiological characteristics of each state. This is when the ventral vagus is active, and like I said, we feel calm. Maybe we're with friends or loved ones. We can think clearly. Another important characteristic, when the sympathetic is active, or even the dorsal vagal, we can't think clearly. I'm sure many of you have experienced this. When you're at a high level of stress, you cannot think clearly. And so here, this dark red / purple is really when you can see someone really shutting down or in shock. There are so many ways to use this tool. You can recreate it, or until recently it was available on Amazon, but I don't see it anymore, sadly. But there are similar worksheets in the Deb Dana's book. Just real quick, one more suggestion. You can just have this list of levels of activation, and as you work with your client or couple of clients, you can ask them just to recognize where they are right now. They can look at the characteristics, the words at the top, and try to identify where is your nervous system right now. And then if you talk about a recent event, you can ask them, where were you then? Which level was what you were experiencing back then. So I'll move on. Because it's 9:45. Okay. So Sibi talked to us about triggers, and I want to add, again, polyvagal theory to me gives me hope. It makes me feel more equipped, more empowered to work with these difficult impacts of traumatic events. Debzena talks about triggers, it should be triggers, plural, and glimmers. The same way that an event such as a baby shower of a friend can bring you into the place of high level of stress, feeling fight or flight, or maybe even immobilized, the same way a glimmer, an event or experience or a person can bring you to your green zone, to feeling calm and content. And I can see messages in the chat, and I just want to check real quick if they're for me. Nope, they're not for me. I had never personally thought of safety as a moment, but you can experience safety in a moment. If you do receive a hug from a person you trust, from an attachment figure, if you play with your puppy, whatever it may be for you, there are things that if you help your clients identify and maybe even make a list, you may empower them next time they feel immobilized to try and find a glimmer to bring themselves back to a state of the dorsal vagal. And our goals as counselors, as you can see here on the slide, are to predict, to try and identify what could be a glimmer for our client, help them to manage those, and maybe even recreate them. At one point when they're ready, maybe even in a state of feeling fight or flight, they will remember, oh, let me reach out to my neighbor. She's on my list of glimmers, for example. Another tool, I will try to be brief. Again, this is from the same book, Deb Dana's on polyvagal theory. I recreated this table.
Sorry to interrupt you. I don't see the slides. And I still see the table that you showed.
Oh, I'm so sorry. I've been seeing the slides. Thank you for letting me know. Okay, let me now start sharing again. But this time I'll pick this one. There are so many options. How about now? The slides? Okay, good. Thank you.
Yes, no, it's okay.
So this was no. So you weren't able to see this one?
No.
That's okay. I covered glimmers. I think this could be very helpful, and I have indicated the page here from the book. I've recreated it. It looks a little bit different in the book, but really on the left-hand side, you can see the 3 levels of activation, and you can help with your client fill out these boxes together. Things I can do on my own. What helps me stay here? How about you all think for a moment, what can help you stay in the ventral vagal zone? I know for me, when I'm outside, outdoors in nature, unless it's too hot or there are mosquitoes or something makes me uncomfortable, if I'm outside in nature, I'm usually getting to my happy state, my calm. My ventral vagal must be activated. Now, when you're in your sympathetic level of activation and you feel tense, on, stressed, what moves you out of there? Make a list with your client. And again, let's identify when you're immobilized, what moves you out of there? For one of my clients, there was only one thing: to start playing episodes of Friends and binge watching, whatever it may be. Now, what happens is if a client cannot identify any signs, any events related to the ventral vagal state, then you help them use their imagination and maybe imagine one if they haven't experienced one at all.
Yeah, so I'll try to quickly cover this because I think it's very important to consider the culture. So when we work with clients, it's very important uh, to learn what are their norms in their culture and what are the expectations of childbirth and parenting. What are their beliefs about fertility treatment, because it's easy uh, to recommend, like do in vitro fertilization or something like that, but for some cultures it is not acceptable and it is considered unnatural. Then we have to learn how grief is expressed in this culture and how people talk about that in their families or in their society, because there are cultures that even mentioning the word death is considered bad luck, so people don't talk about it. um, then what are the beliefs about life support, taking off life support, because there are a lot of ethical decisions that has to be made usually when there is a sense of emergency, so people can regret about these decisions long after that. uh, and they can be judged by other people in their culture. Then what are the beliefs about blood transfusion and many things, like for example, when I was going through such an experience, and it was soon after I moved to the United States, it was very difficult for me, like, to hear this question like, how are you? And here you have to respond that I am fine, thank you. But in my culture, I'm originally from Bulgaria, like if you ask somebody how are you, like you expect a honest answer. So for me, it was I was experiencing this dissonance inside of me that I cannot, or that I'm lying from what I'm saying. So all of these things, they can seem like very small, but they are important. So we have to address them.
Thank you, Sue. Absolutely. As counselors, we know how important multicultural competencies are. I already spoke a little bit about countertransference. Was this our final? No, it's not. Oh, we have a few more. Well, do we have time, Caitlin? Are you here, Caitlin?
You have it's 8:51, so maybe leave a few minutes for questions if you would like to go over your last couple of slides.
Thank you.
Mhm. Well, maybe like gaps of the care, we can skip this. Obviously, there are gaps, so we can just skip and go directly to the training that is available. So it is good for counselors who want to address this type of clients who experience this type of problems to have a specific trainings. And some of the specific approaches that they can adopt is they may need to do sexual counseling. They have to address grief. So training in grief counseling can be helpful. Group therapy is also very helpful for people experiences perinatal trauma, because it is something that can help with the feeling of isolation. They can share with other people and see that other people are going through the same things. EMDR is a good approach because it addresses the feelings of the body, and as we said here, there is also a physical trauma, not only psychological. Cognitive behavioral therapy, I would say that counselors have to be careful when using this, not to focus so much on the like logical part of the brain. Here it can be helpful by teaching people how to uh, like to apply self-care and how to be assertive and how to communicate with others about what they are experiencing. Of course, journaling, art therapy is very helpful. And again, these other approaches that are focused more on the body, like Chinese medicine, yoga, qigong, and massage, because a lot of this trauma goes in the body. And
I just want to mention that we already had a question about sharing the slide.
I'm sorry?
Oh, There was a question about sharing the slides with the
Oh,
attendees.
okay. Okay. Yes, we can do that. We can do that. So from this slide, maybe I will just focus on the last thing that we put here: be present and listen. It's important for counselors to remember that like these events, they cannot solve this. If a baby dies, it's devastating, and they cannot solve this. They cannot fix it. So it's very important to give support by being present and just explore our own feelings and beliefs in order for us to be able to be supportive.
Yes, exactly. We have to be self-aware so that we can continue to show warm, empathetic presence, even at the mention of traumatic events and experiences, so that we engage the client's ventral vagal pathway. And I think this is, yes, this is our final slide.
Mm-hmm. Yes, again, yes,
self-explanatory.
This goes with what we mentioned last. These do's and don'ts are not only for, they are usually inappropriate things that people hear in society from friends and family, but unfortunately I have heard some of these things to be said by counselors. So it is important to remember just to stay supportive and explore what the client is experiencing, what are their own beliefs, and just join them in their struggles and give them support and say that we are there for them and we are not there to fix what happened, because it's not fixable.
Thank you, Sibi. I just wrote down the email that we're going to use to share the slides. And I guess we do have a couple of minutes for questions.
We do have one question. When you mentioned anxiety, depression, and PTSD through the polyvagal lens, could you talk more about this?
Yes, I would love to bring up real quick. I have to stop sharing again the handout with the levels of activation. Can we all see again the colorful handout? Okay.
Yes.
Yes. So what is the DSM? It is a system of categorization of disorders based on symptoms. Some of them are visible, some of them are behavioral characteristics, and others are self-reported. We have no idea how to see it on the outside really in a reliable way. Some of the symptoms are just the client has to report that they have experienced them. This is different. This to me is more reliable. This is based on physiological characteristics that show us what level of activation the nervous system is at. So we're not speaking anymore of disorders. We're speaking about a continuum between, and Dan Siegel, Dr. Dan Siegel, who talks about mind sight and interpersonal neurobiology, he's saying that we're going to shift at some point in mental health with diagnosing mental illness and mental wellness on a continuum between from chaos to rigidity, and anything in between is just a level of tension. Lack of tension is chaos, too much tension is rigidity, and he says that pretty much all of the DSM categories we can fall on somewhere on this continuum. So I think it's very exciting. I don't know what this shift is going to look like, but if you don't have to diagnose for insurance purposes, I prefer to use this level of speaking in terms of colors, in terms of the titles of each section here, and in terms of the pathways of the nervous system. Are there other questions?
Does anybody have any other questions for the presenters?
Also out of time. Well, thanks to all who was here today.
Thank you so much. I hope it was helpful.
Thank you, Maya and Sibila.
Thank you.
Thank you, Caitlin.
Take care.
Bye-bye.
Bye.
Caitlin, it might be easier for you if when you're in here as a room monitor, you can actually rename yourself. So you can rename it so you don't show up as Dr. Hudson. I mean,
Okay.
impersonate Dr. Hudson for the day.
Okay.
But just make sure that when you leave, you rename it back to Danita Hudson.
Okay.
Okay. Thank you both for presenting our first presentation. That was wonderful. Thank you.
Thank you.
Hi, JJ. Hi, Andrew.
Hi.
Good morning. How are you, Dr. LA?
I'm good. How are you? And Dr. Van Meter? I saw Justina earlier. Oh, there she is. Welcome, everybody.
Sorry, Dr. LA, I was eating my breakfast. It's still early here.
I know, really early for you. Really early. I was like, you're presenting it at Eastern?
Yes, dedication.